Hi guys, I'm going to be trying to do this, another little voice recording to see if this helps at all. I'm doing this in chapter 32, and unfortunately there's only going to be 2 questions on this fucking chapter, so, there's probably going to be a bit more information here than you need, but it might help you in the future, and hopefully I can explain it to you. So again, my disclaimer is that I'm not guaranteeing that every single thing I'm saying here is right. I'm kind of interpreting the book's information in my own way, and I've watched YouTube videos to try to help me understand the material better. So let's get started. So this is going to be on transfusion reactions and also different types of transfusions. I have not gone over the CBC count because I could not find the table, or the CBC, the abnormal values of this complete blood count or whatever. So we'll start with the different types of transfusions. So there's standard, autologous, I hope I said that right, intraoperative, and hemodilution. Standard is just your basic, transfusion where the person's just receiving blood, or you're donating blood. Person's just receiving blood. Really no complications. And of course there's like a policy procedure that you have to follow, and yeah. So autologous is when the individual is donating blood to themselves. So they might do this to save up blood for some reason. Maybe they expect to be in an accident, or they have a surgery. They're having an upcoming surgery. And usually they would get this 4 to 6 weeks prior to the procedure. And the primary prevention of an autologous donation is it can prevent viral infections. Okay, there's other benefits, like, somebody that has had reactions in the past from transfusions, but this is the primary advantage, is prevention of viral infection, because if they don't have an infection and they're getting their own blood, they're not going to get a viral infection from themselves if they don't have a viral infection. So next we have intraoperative. Blood lost during procedure is suctioned and re-administered. Okay, so that is, I think, pretty commonly used now. So the blood lost, it gets put right back into them. Finally, we have hemodilution, which is before surgery, the doctors will take out, or somebody will take out 1 to 2 units of blood and then replace it with a solution, some sort of solution. So this is crystalloid solution. And then after the surgery, the blood is reinfused. That way, less blood is lost during the surgery. So if we think about it, when we administer, let's say, or water, or how about this? We have orange juice. Okay, we have a little orange juice, and then we pour the water in there. Now we have, a diluted orange juice that's like diluted, orange juice that is diluted. So there's more orange juice around the cup or in the water, but there's just not as much orange juice per square inch of that water. And that's kind of what they're doing with the surgery. So when they're losing blood in surgery, there's less blood per square inch because there's more solution, there's more water in that blood. Does that make sense? So more water in blood, less blood per square inch. Less blood lost when they're bleeding during surgery because there's less blood per square inch. I hope that helps you understand. If you don't, I can try to explain it to you later. Next slide. Febrile non-hemolytic reaction. Our body's antibodies. So this is when our body's antibodies react to leukocytes in the donated blood. So sometimes our body doesn't really like, or our antibodies attack the white blood cells that are still in the donated blood. And that's what kind of causes this reaction. So people at risk are those exposed to antigens previously in life. So an Rh negative mother and somebody that has had multiple blood donations. So somebody that's just been more exposed to different types of blood might have this problem. Reactions to this, or the symptoms, would be a slight fever, typically at least plus 1 increase in Celsius. So it would be 38.5 plus, because the normal values are 36.5 to 37.5. They could also have chills and muscle stiffness. Now, this is not life-threatening. So what you need to do is you need to relax the patient, because they don't know what's going on, so they're assuming the worst. The reaction can be diminished or even prevented using a leukocyte filter on the donated blood. So if somebody's had this reaction before, you can, filter the blood and get the leukocytes out so they won't have this reaction again. When this kind of reaction occurs, I'm pretty sure you should be stopping the transfusion. I heard that you can continue on if the person feels better, but I'm not sure. Next is acute hemolytic reaction. This is the most dangerous and potentially life-threatening reaction that can occur. And this is when the antibodies react to antigens on donated cells. So remember, this is basically when somebody is blood type B and gets a donation of blood type A. They do not mix well, because the blood type B, the person that's receiving the blood that's a blood type B, has blood type A antigens or antibodies in their blood. And when that blood type A is introduced, the person's blood type A antibodies are going to kind of attack those A cells. I'm sorry, hopefully I made that sense. Okay, so the most common cause of acute hemolytic reactions are errors in blood component labeling. So the reason this happens a lot is because somebody's probably tired at work and they are kind of messing up the labeling. So there's going to be an error in the labeling of the blood, or there could be an error in identifying the patient, right? This is categorized as a type 2 hypersensitivity reaction. So remember, there was like type 1. There's like 4 types of hypersensitivity reactions, and this has to do with immunology. This is a cytotoxic hypersensitivity reaction. So, yeah. Sorry, I don't have much to say about that. So people that have this would experience low back pain, fever, chills, chest tightness, nausea, hemoglobin urea, which is blood in the urine, hypotension, and bronchospasms. Allergic reaction. So plasma protein of donated blood thought to be responsible. So there's something about the donor's blood contents that our blood does not like, and there's a little fight because of it in our body, basically. What will happen? So how I remember this, the symptoms of an allergic reaction is just with blood is just think of an allergic reaction that happens for anything else, or think of the symptoms that come from or that arise from an allergic reaction with anything, like itching, generalized itching and hives, very common symptoms of an allergic reaction. These are usually mild. An antihistamine may be administered, and surprisingly, you can, if the person calms down, if the symptoms go away, you can continue the transfusion. In the future, if this person has a problem with with blood, with blood transfusions, you can give them an antihistamine prior, or a corticosteroid prior to the blood transfusion. Next, we have circulatory overload. So this is when an infusion is administered too quickly, causing hypervolemia. So let's break down hypervolemia. Hyper, excessive, or over, or something, or just increased. Volume, and then emia, like condition. So, or ea is a condition. So a condition where there's an increased amount of volume. Okay, so signs of circulatory overload include dyspnea, orthopnea, tachycardia, and sudden anxiety. So I would be fucking scared if I didn't know what was going on. Jugular vein distension, right? Because there's an increased amount of volume. Our vessels are going to be bulgier, right? Crackles at the base of the lungs. So I just think of, fluid leaking from these vessels. Not really leaking, but just fluid kind of leaving the vessels and kind of dripping into the lungs. So you'd have those crackles, or when you auscultate. And an increased blood pressure. Why is there an increased blood pressure? Because there's an increased volume of blood, or volume in the vessels. There's less room. If overload is mild, infusion can continue at a decreased rate. I'm not sure if you would stop the infusion at the sign of an circulatory overload, if it was like a mild overload, or if you would just decrease the rate immediately and then check and then see if you have to stop it. If the circulatory overload is severe, sit the patient up. Transfusion is discontinued and PCP is notified. Okay. When I think of sitting this patient up, I think I'd rather have fluid in my legs than fluid in my upper body, like my lungs or something. Diuretics may be given. Remember, diuretics increase your output of, or fluid output. Like peeing. It would make them pee. So, next, because I only have 5 minutes, I only have 15 minutes to give this thing with this program. Bacterial contamination. So it can occur at any point of a procedure, but most often from donor skin. So when somebody is donating their blood, I guess when they, start taking their blood out, right when they insert that needle, that needle could pick up bacteria, and that bacteria could go into the blood. Platelets are at greater risk for contamination, and this is because red blood cells are stowed in a freezer, and bacteria has a harder time living in cold temperatures. Okay, platelets, on the other hand, are stored at room temperature, and bacteria doesn't have as difficult of a time surviving in those conditions, in regular conditions. Transfusion is should be less than 4 hours, because the longer that this transfusion is, the more time this bacterial growth the more time this bacteria has to grow, because the environment is warmer. Signs are fever, chills, and hypertension. And when you suspect somebody is subject to bacterial contamination, you should stop the procedure. If left untreated with broad-spectrum antibiotics, this could lead to sepsis. So remember, what broad-spectrum antibiotics are just antibiotics that attack a wide range of different infections. That's really it. Finally, we have a delayed hemolytic reaction, where antibodies have increased to where a reaction can occur. So imagine that you get a reaction, and initially your body's like, I really don't know what the hell this is. I've never even prepared for this kind of situation. So over time, after that reaction, your body's starting to develop antibodies. And, within 14 days, there still might be some of that blood left in the body or in the system, or there will be blood probably still left in the body from that donation, and then there could be some sort of reaction occurring because of that, because your body has developed some antibodies enough to fight off this new antigen that has just been introduced. Signs and symptoms of a delayed hemolytic reaction are fever, anemia, increased bilirubin level. Bilirubin is just what is made after your blood cells break down. And then when it says possibly jaundice, bilirubin has a yellowish pigment, has like a yellow pigment, and then your skin would turn yellow because of the increased bilirubin as a result of your blood cells breaking down. So it should be noted as to prevent a possible severe. So usually a delayed hemolytic reaction is typically not super severe. Or it's like a mild thing, so it's not really that big of a deal. But the person needs to report this, because in the future, if they have a transfusion with the same type of blood, their body will be prepared for like a war, and then a severe hemolytic reaction can occur. I hope this has been helpful. I want to make a chapter. I want to make this kind of thing, or I want to make a little recording for every chapter just to help myself and hopefully to help somebody that needs extra assistance. So, no problem. See ya. Bye.